Hi, this is Professor O'Connor, and I am going to be teaching acute respiratory disorders in children, and this is part 1 of 6 parts that you need to complete prior to coming to class. And I'm making this as a video, and I will then post the notes as a handout for you. So this is going to cover commonalities and maturational differences. I have listed here the normal respiratory rates for the newborn, infant, toddler, preschooler, school age, and adolescent. And as you can see, the newborn respiratory rate normally is between 30 to 55 breaths per minute. And as the child grows, the normal respiratory rates decline, so that by the time they reach adolescence, it's 12 to 20, which is pretty much the same as an adult. The key point for you to know is a child who has a respiratory rate of 60 or greater is at very great risk for respiratory problems. You need to read your textbook, Chapter 48, pages 1388 and 1391, which go into great detail regarding variations in the pediatric anatomy and physiology. These 2 pages will tell you the exact differences between the adult and the child for these. I will go into detail for some of them, but you should read all of them, take notes on them, because you will be responsible for the information. Okay, so this is one of the key points of a difference between an adult and an infant in the respiratory system. And in an infant, the trachea is only 4 millimeters wide by diameter and 2 millimeters by radius. And in a normal adult, the trachea is 10 millimeters wide with a 5 millimeter radius. And so when you reduce the circumferential edema, you reduce the actual lumen by 1 millimeter, it's going to cause a 50% reduction in the diameter and the radius. So that means in an infant it's down to 2 millimeters by diameter, 1 millimeter by radius. And that will increase the pulmonary resistance factor by a factor of 16. All right, and then in the adult, if you have 1 millimeter of edema, that's going to reduce the lumen. It's going to reduce it to 8 millimeters with a 4 millimeter radius, and so that pulmonary resistance is a factor of 2.4. So the difference is like asking an infant to breathe through a coffee stirrer. So another big variation is in the normal adult eustachian tube, it's longer and it's more vertical, and in an infant it's shorter and it's more horizontal. And so that means that it's much easier for fluid to back up the eustachian tube and enter the middle ear and thus cause a middle ear infection. So I want you to review pages 1397 and 1398 in your textbook. It will go over and go into great detail about the chest x-ray, arterial blood gases, which is an invasive procedure and gives you actual partial oxygenation and partial CO2 levels and pH. There's fluorescent antibody testing, which is used to test for RSV and other viruses. There's pulse oximetry, which I believe you're familiar with, and that checks for oxygen saturation in the blood. However, the sender and the receiver have to be opposite each other for it to be accurate. There's a rapid strep test, which will test very quickly for strep, beta strep group A. And then there's the throat culture. And the throat culture takes 24 to 48 hours to come back. And at the 48 hour, it will identify the exact bacteria as well as sensitivities for different antibiotics. There's also allergy skin testing, peak expiratory flow, pulmonary function tests, the RAST test, sputum culture, and sweat chloride test. Professor Thomas will be discussing these under the chronic respiratory section. The last of these are listed on those 2 pages are the tuberculin skin test, sinus radiographs, rapid flu test, gastric washings for AFB, and fluoroscopy. We are not covering these in our course. Some common medications that we will be talking about are antibiotics, both oral and parenteral. They will only treat bacterial infections like tonsillitis. you need to check for allergies and give the prescription for a full number of doses. The beta-2 adrenergic are short-acting, and they relax the airway, help diminish wheezing, and generally work in the lower airway. Racemic epinephrine is used for croup. It relaxes the airway and is generally used for the upper airway. Corticosteroids, both oral and parenteral, suppress inflammation and are used for severe croup. They may cause hyperglycemia. They may suppress reaction to allergy tests, so consult an MD if vaccines are due, and a short course is generally safe. Virazole, or ribavirin, is a treatment for severe bronchiolitis. These patients are usually intubated. They require suctioning every 2 hours and usually pulmonary pressure checks every 4 hours. There is concern regarding administration by a pregnant caregiver, so we don't see it used much except in intensive care units. Synagis, or palivizumab, is a monoclonal antibody, and it's used to prevent serious lower respiratory RSV disease in high-risk children. These children are identified, and it is administered monthly during RSV season, and it is given via an IM injection. This is a picture from your textbook that are 3 methods for delivering oxygen: face mask, nasal cannula, and a rebreather mask. There is a 4th one, which is blow-by oxygen, and you use either a scoop mask or a corrugated tubing, and it's wrapped a towel around the end of it, and so then the oxygen blows by the infant or the child, and they inhale the oxygen. So non-nursing interprofessional collaborative care, we might require the services of physical therapy, respiratory therapy, nutritional services, social work, and child life services. I have on this a YouTube clip, and I'm actually going to be showing it as part of your requirements. But this is the URL for the YouTube clip about child life services at Tufts Medical Center. Okay, so I have a question here. A 4-year-old is seen in the clinic for a sore throat. The most likely causative agent in the child's mind is that he either was exposed to someone else with a sore throat, did not eat the right foods, yelled at his brother, or did not take his vitamins. So I want you to take a minute and to think about what the correct answer is for this question. So the correct answer actually is that he yelled at his brother. This is a 4-year-old, and so preschoolers understand some concepts of being sick, but not the cause, so 1 would be out. 2 and 4 could be factors that would cause a child to become sick, but are beyond the understanding of a preschooler. 3 indicates the development of a preschooler, where they think that if they did something wrong, they are punished by becoming sick. And so the correct answer is he believes that he got sick because he yelled at his brother. This is the end of the first section, and the next thing to do is to view that YouTube clip on Child Life Services at Tufts Medical Center, and then go on to the second part.